Hi everyone, my name is Shaina Rozell. I'm a hematologist-oncologist here with Affiliated Oncology. I also practice out of Advocate Christ as well as Advocate South Suburban. My emphasis is both hematology and oncology, so I see multiple myeloma. I run a genetics clinic at Advocate Christ and also am very instrumental in our teaching hospital at Advocate Christ.
Hi, I'm Mouhammed Kelta. I'm one of the practicing hematologist-oncologists at Advocate Christ Medical Center and affiliated oncologist. I consider multiple myeloma one of my favorite topics.
This is MD Newsline. Today's topic is multiple myeloma and overcoming the gaps in treatment and overcoming disparities.
It's my understanding that multiple myeloma impacts different populations differently. Can you talk a little bit about the differences in the prevalence and incidence of multiple myeloma in various populations, and which populations are most heavily impacted?
Right, multiple myeloma is considered the second malignant disorder. If you take all comers, the African American on average will have a double incidence as compared to Caucasians. The annual incidence nowadays is considered around 36,000. Again, that African American represent 14% of the population, and they would among the patients with multiple myeloma, they are about 20% of those who have compared to their Caucasian counterpart.
Why do you think that is?
Really, I mean, it comes down to the genetics of it. Nobody knows exactly with the right answer why that African American would have a higher incidence rate. As I said, it's usually around 2% for all population. On average, African American will have double that. Now,
you mentioned genetics. Are there epigenetic factors that we've identified?
So interesting, there are not really any epigenetics that we have identified, and those are the questions that we typically receive from our patients. Why did this happen? Is there something that I've done? Is there something related to any socioeconomic factors that may have contributed? But for this disease, unlike many others, there is none that we have really identified.
So are there differences in the presentation and symptoms of multiple myeloma in different populations? And are there any key differences that you want to point out?
I generally don't see a difference in the main presentation of multiple myeloma. Those who present usually have a general symptoms, usually fatigue, and this is related to anemia. They may have weakness. They may have worsening kidney function because of the myeloma protein. So for the most part, they really present similarly. However, the degree of reporting of those symptoms is different among different cultures. So some people tend to rate more symptoms, and they don't present till a late stage where they have really very advanced disease.
Yes, I would agree. I think, in my practice and even going to different areas, in the city, if you're more in an urban area versus a rural area, you would really see the degree or difference in presentation. Certain cultures, we really understand that patients may go to each other, they may go to their churches, they may talk to family members about these symptoms and what to do, and everyone has their own antidote. And it's not really until they're at a later and advanced stage that they actually seek medical attention. And that's a whole plethora of reasons, right? We know all of the stigma that is associated with coming to, see the doctors. So for that reason, we do see different populations, different minorities seeking health care at later or advanced stages.
And the other part of this story is that physicians may not recognize those symptoms early on, and they may blame the high blood pressure or diabetes for the symptoms, and on average it takes about three visits for a medical physician to pick up multiple myeloma, and usually it takes some effort from the patient to show up on time and stick to their clinic, go through the testing, blood testing and urine testing and some imaging study. So that's why on average it takes 3 visits to get the diagnosis right.
So how does multiple myeloma typically start, and then at which point in that journey do people typically, the people who are most impacted, end up in front of a doctor?
Let's think about it, yeah.
Because there's a variation. So it depends. So I would say those patients who actually seek care or who actually go to their doctors may be getting blood tests, and that astute physician may say, I see a protein gap. Something may be up. And I would refer you to a hematologist who is then going to evaluate you for that. But it's different for those patients who don't even seek healthcare from a general internist or a primary care doctor, right? And so, as Dr. Kelta was saying, many times they're attributing their back pain to something else, and by that time, now they already have some lytic lesion or change in their spine, and that is considered multiple myeloma. And so, in that case, that patient is coming at a later advanced stage. On the flip side, again, you may have patients who are a little bit more aggressive in getting blood work and following up and taking a little bit better care of themselves, as far as going to the doctor regularly, they may be diagnosed earlier.
Are there any key symptoms? And if not, how can people get to early detection?
So I think that's a really good question. I think it's very hard to diagnose multiple myeloma. In fact, there is no screening test for multiple myeloma, and it's not like you're going to your doctor for a mammogram or you're going to get your colonoscopy. This is a little bit different. A lot of times you're not detected until you have symptoms or until you're having just plain old blood work that prompted someone to actually decide that this needed to be investigated more. So I think that's a challenge, at least for diagnosing multiple myeloma at this current time.
I would add there is no standard screening. For male, we have the PSA, we have the colonoscopy. For female, we have the mammogram, but there's no standard screening test for multiple myeloma. However, when patients present to their primary care physician and they have unexplained hypercalcemia, or they have unexplained worsening kidney function, so this can trigger some of the workup. On average, we have 2 blood tests that we do and 1 urine test. That, for the most part, this will give us almost 97% certainty that we have something called plasma cell dyscrasia, under which multiple myeloma is reported. So, yes, there is no standard testing. However, there are tests. Once they are done, they are very informative.
But I think also you have to really be an astute physician, because how many patients are coming in for worsening kidney function that you may attribute it to high blood pressure or diabetes. This is the first thing that doesn't come on your radar is multiple myeloma, right? It's let's fix their blood pressure, let's fix their diabetes. It is not until you actually see things that are concerning in the blood test that make you say, could there something else be going on?
And that's what basically the challenging diagnosis, and that's part of the delay in getting the diagnosis right and then starting correct treatment.
Really, unfortunately, there's no test. There is not. I have patients who are very healthy who have been diagnosed with multiple myeloma. On the flip side, I have patients who have a lot of medical comorbidities who also have been diagnosed with multiple myeloma. And the unifying theme is maybe they may have a gene mutation. Maybe they've lived in a certain population. We don't know. Maybe they have a family history. There's still no identifiable feature even in family history. So I know, we wish we had an answer. We don't. Unfortunately, we don't, guys. We do not have an answer. I wish we had one, but we don't.
All right, I'll move on from that one. No, so how do you weigh the benefits and limitations of different diagnostic modalities? Like, are there some that are your go-to to make sure it's not, or, so how can a doctor kind of help stop a patient from going through all of the steps when it's like, this test could really give you an answer?
I think I will take this one. If once you see somebody who think of having multiple myeloma, I think the starting, as I mentioned earlier, is a blood test and a urine testing, and in which we assess the end product of this plasma cell that can trigger the disease. It's called protein electrophoresis, and this is a serum. And then we likewise we do urine protein electrophoresis, and this will pick up we call it myeloma protein, or the so-called M protein. And the other test we do immune fixation, and this is for the serum and urine, and this will tell us what type of M protein there, or myeloma protein, because they have subtypes, IgG, they have IgM and IgA. So the immune fixation will identify that subtype. So now we have yes and no for M protein based on serum protein refuses, and then we have the subtype on immunofixation. Now, and then there is a relatively more or a newer lab that added to the testing. It's called the serum-free light chain, and this is a very sensitive test. So if we add the serum protein erythropoiesis immune fixation, plus the serum-free light chains, plus the urine immune protein immune fixation, I think you would be certain for I would say probably 95% of the time that you get the right diagnosis. Again, if those positive, then you need to end up doing bone marrow biopsy to look at the plasma cell percentage, because myeloma is a spectrum, or a plasma cell dyscrosia is a spectrum. Start with something called monoclonal gammopathy of unknown significance or uncertain significance, to something like in between called smoldering myeloma, that's not quite myeloma, made it, and then all the way to multiple myeloma. And then there is something called the International Myeloma Working Group. They come up with definition for each one category of those. So if you have the serum and urine testing, and you have the plasma cells from the bone marrow, you can characterize your patient to which group he belongs. Is it like the beginning of the spectrum, which is MGUS, monoclonal gammopathy, or smoldering in the middle, or multiple myeloma full-blown? You would probably miss, I would say, about 5% of the cases, because some of the myelomas do not produce protein that you can pick. We call them non-secretory multiple myeloma. So that's why, anyway, if you did not pick it up from the blood or urine, they would be able to pick it up from the bone marrow biopsy. Now, once you're done with all this, you have to do some bone imaging. Remember, this is a bone marrow disease, so the plasma cell reside in the bone marrow. It can cause local damage. It can cause even pathologic fractures. So you wanted to be ahead of the game and do those imaging before they miss the boat. And if they have some weak area, you may want to address before the fracture. And once they get fractured, that's very morbid.
Right. Yeah, I think also in my training, we were doing tests, and so you may have heard of skeletal surveys, and those were kind of the standard of care at that time. But we realized that there were changes kind of in these bones that we were not picking up at an earlier rate. And so now, as time has improved, or we've improved in our tests, we're now looking at PET scans as well as MRIs to kind of help and diagnose these subtle changes a little bit earlier. I think that Dr. Kelta alluded that it's really tough because you're hoping that you're not missing patients who have developed multiple myeloma. You have this earlier spectrum of MGUS, or even the smoldering, and those are those patients that are teetering towards multiple myeloma, and you're just hoping that you are capturing them earlier before they develop into a full-blown multiple myeloma. And these are some other ways to kind of help diagnose it.
So as far as the populations that are impacted the most, are there any of these tests, these initial tests, that seem to be more effective for certain populations, or even more accessible to certain populations? And we can talk about the accessibility insurance later, but let's talk about if there are differences in effectiveness for certain populations that present with a certain type more often, or something along those lines.
I don't see differences. Those tests are readily available in most centers, and they even for small communities where they cannot have the facility, they can send it out for other more advanced lab to do it. Those are doable, and they're part of routine now when it comes to the diagnosis of myeloma. I mean, it might be difficult more to get approval for PET CT scan. It might not be readily available for patients who live in remote areas, or their insurance don't approve it. We have been through that, but still you can do a skeletal X-ray, even though it's not as sensitive. At least you can rule out the big bone disease area that can fracture one day, and so this will hopefully prevent those catastrophes.
Yeah, I would agree. I think a cheap and easier test is the skeletal survey. Now we're leaning towards PET scans and MRIs, but I think it is difficulty in getting those for a number of reasons, mostly access to care. Many of the hospitals may not even have or be equipped to do a PET myeloma study. So I think that's a challenge, and that's a whole nother discussion.
Well, let's talk about it. If a hospital is not equipped to do that study, how do doctors advocate for that? What kind of strategies have you seen to make sure those patients get care, and how can patients advocate for themselves to make sure that they get the proper test that they're needed?
So it really is referrals, making sure that they can actually be their own advocate. I think this is the day and age of technology, social media, and you see more patients being advocates for themselves. And so I think that's really, if they learn or have more of an inclination that this is what's going on, then a lot of times the patients are being their own advocates and saying, hey, I would like to see this doctor, or I would like to go to this institution where these tests can actually be performed. So I think that is kind of one way. I think, again, we see the disparities just even in the inner city Chicago, where a lot of different institutions do not have access to the right infrastructure, let alone the shortage of physicians to actually diagnose properly. So making sure that you can actually refer out. I don't see anything wrong with referring out where patients can, get the care that they need.
What is, we've talked about the diagnosis process. What's the typical course of treatment for most multiple myeloma patients?
I would take this. As a start, there are nowadays if you take, but this is interesting. When we started in our training, I would say we used to have very limited options of treatment. At one point in time, it was a pills called melphalan and prednisone. That's how it started. And then the thalidomide, the history is very important. Thalidomide came on board. Thalidomide is one of those medications used for a female who have a nausea, vomiting while they're pregnant, and then they ended up with having babies without arms and legs. They call it Amelia and Phocomelia. Phocomelia losing their upper extremities and Amelia losing their lower extremities. So that was thalidomide. Luckily, thalidomide was not approved to enter the country. That was in the 60s. It was so common in Europe. So they had a major problem with it. Now, thalidomide was, had some spotlights on thalidomide in early 2000 when they said, okay, so what happened to those babies? Why were they born without arms and legs? It turned to be, the thalidomide affect the media that multiple myeloma can grow in, which is the blood vessels. It inhibits blood vessels formation, and that's why those kids came without arms and legs. Well, and if you got the supply on the multiple myeloma and a medication called thalidomide, or now the cousin of thalidomide called Revlimid, it got the blood supply in an immune modulation way, you get an added benefit to the chemical. So now, thalidomide initially, and now Revlimid, which is a cousin of thalidomide, is incorporated into the treatment regimen that's considered very active and potent. Proteasome inhibitor came also on board. This is one of the specific classic starting treatment for multiple myeloma, and prototype of this one is called the Velcade, which is bortezomib, and now we have a carfilzomib. And the other side, immune modulator, we have thalidomide and lenalidomide. So we combine one of the proteasome inhibitor, nowadays is bortezomib, plus Revlimid, and we add to it dexamethasone. Dexamethasone is very potent as well. So the standard in North America now, the standard of care is called VRD, Velcade, Revlimid, and dexamethasone. Now, those who have renal failure, who present with acute kidney injury, remember one of the presentation of myeloma is kidney failure. We replace Revlimid by cyclophosphamide. So we call it's a famous name for it, it's called CyBorD, which is cytoxan, bortezomib, and dexamethasone. So it's either VRD or CyBorD. That's the standard classic initiation of initial treatment for multiple myeloma. However, those who have a high risk, so this is for standard cytogenetics. If they have high risk cytogenetics, that's the TB53 they call it, or they got 414 or 1416. So those we add the monoclonal antibody called daratumumab, anti-CD38. So it's either daratumumab VRD or daratumumab CyBorD. That's a standard initial treatment based on risk. We stratify them based on risk and based on end organ damage.
Yeah, and I think multiple myeloma is becoming one of those cancers that have become very complicated. And why is that? So before, we looked at patients as being bone marrow transplant candidates or not being a bone marrow transplant candidate. And that is based on a lot of different factors, age and all these medical comorbidities. Even Dr. Kelta, does bone marrow transplants. But we learned that, nowadays, patients are doing very well and living much longer, even just with all of the medications that have been developed. And as Dr. Kelta was alluding, now it's not just the patient comes in and you're putting them on the same medications. We're looking at different cytogenetics, so different factors where one may have a worse prognosis than the other. If they have a worse prognosis, then you're giving them an additional medication. Sometimes we're doing what's called a quadruplet. How many patients have you put on quadruplet chemotherapies?
Quadruplet, and it depends on risk. If they have high risk, I will do it.
Yeah, so it depends on all of those things. But most commonly, many of the patients we're putting them on what's called a triplet: VRD, Velcade, Revlimid, and dexamethasone. So that is typically our standard of care. But you may see some variations. There are patients who may not even be able to tolerate Revlimid because of other side effects. And even those patients, you may decide and you may make some changes depending on those comorbidities.
And I was going to ask about, these comorbidities. What are the most common comorbidities that create complications in the standard course of treatment?
So some of the most common comorbidities that may impact your decision on what types of treatments to use. So I would say, there are a lot of different variations. So one, the performance status. So is this a patient that can actually tolerate some of the medicines? Revlimid has a major issue with kind of thrombotic events. And so if a patient, for instance, has been more prone to PEs, DVTs, it may be something that you might consider avoiding. Even with that medication, we are putting them on what we call DVT prophylaxis with either aspirin or any DOACs. So that is kind of a way to get around it. You also have patients who have florid heart failure, and so those patients you may consider not giving them, for instance, carfilzomib, which is another medication similar. But then it's also feasibility. Can they actually come into the office and actually receive treatment? Velcade, for instance, is typically given every week. Can they come in every week to get an injection? Transportation may be a major struggle, especially in some of these rural settings. And then for those reasons, maybe they need to take a pill. So I think there are a lot of different strategies that we have come up with to kind of address some of those issues. What would you say?
I agree. Even for any given protocol, there are different ways of doing it now, and we usually select the easier way of, let's say if you take an example of Velcade, you can either do it weekly, as you mentioned, Dr. Rozell, or you can do it like day 1, 4, 8, 11. That's a standard regimen, and I found it easier for people to come weekly. I would say this is not as difficult as day 1, 4, 8, 11.
Yeah, I don't think my patients prefer to come every 4 days.
1, 4, 8, 11, yeah. So we came across, and then there are different protocols now. We stick to try to make it as as easy as possible. It's never been easy.
Do you utilize things like CAR T therapy? Is that something that is useful?
I will go just to make it like streamlined, and I would go through autologous transplant before CAR T cell because that's the standard now. Okay. And typically speaking, after a standard induction phase, which is somewhere between 4 to 6 cycles of treatment, and this will take us to 4 to 6 months of treatment. Obviously, throughout the time of treatment, we assess response, and that's mainly to follow up on M protein, that's a monoclonal protein in the blood and urine. And then typically, if we are, we're seeing a response based on those lab tests, we perform bone marrow biopsy, and this is usually after 4 to 6 months. If we get to something called like a more than partial response, meaning we really achieved a debulking of the plasma cells in the bone marrow as well, with significant reduction in the protein in the blood and urine, we move to the next phase, which is autologous transplantation, and this is considered the standard of care. It's part of standard of care regimen. So it's not only chemotherapy. Incorporation of autologous transplant is definitely part of it. Now, there are two schools of thoughts. One is to take him, if they achieve better than partial remission, that's very good partial response or complete response, they go for autologous transplant either upfront, right after 4 to 6 months of treatment, or collect the stem cells and transplant them after they relapse. And I can tell you, the mainstream now is to take them up front, because if you wait a few years down the road, they may not be in as good a general health by then. So I would say if you ask 10 hematologists or 10 transplanter, would you do transplantation right up front, or you would collect stem cell and do it later? I would say the majority will go for stem cell up front.
Yeah, I think I would agree.
Yeah.
What are some of the cultural and kind of systemic hurdles that doctors might face in trying to either advise patients on courses of treatment, since there might be mistrust of the medical system? What are some of the cultural and structural things that you often come against when you're trying to give treatment to the
Maybe I can start and you can complete. I think part of success of treatment is being in close to a healthcare system where they can provide you with appropriate care. You have to have a health literacy to understand what the disease means, and then how to go about the treatment and the side effect of treatment. You need the family support and caregiver availability. You need the financial aspect is very important here, because not only they're going through a intense course of treatment, they're off work for the most part. So on one side they are paying more money, on the other side they are getting less income. That's all will boil down to it. And there is some, I would say, pretty misunderstanding of involving patients in a research. I would say just it's part of how we advance medicine. Patient, when you tell them I'm going to consider you for research, the first reaction would say, please don't put me on placebo. This all will contribute to getting appropriate care, I would say. Yeah.
And I would agree with everything that Dr. Kelta is saying. I think one of the limitations that we see is really enrollment in clinical trials, right? And we know that, for instance, and there's been a major push to put more minorities on clinical trials. There is a lot of reasons why that is not happening. There's a lot of reasons why there is, a lot of mistrust for physicians. And I mean, we can even just talk about even recent like COVID dynamics and whether or not to get a vaccine. There's a lot of mistrust about all of this. So, I can talk about a patient I just had yesterday who actually has multiple myeloma, and she did not want to be on, Revlimid because she got a PE, and she blamed it to the Revlimid, but she actually had COVID as well. And so what we know also about COVID is that there's an increased risk of thrombotic events. And it took a lot of, coaching and prodding and saying, hey, you're actually on a blood thinner. I think it would be okay to be on Revlimid, because we should start, from scratch and have you on a treatment that may actually work. And so I finally convinced her to actually decide to actually get treatment. So it's having a relationship with your provider, being able to identify with them, what you say. I think I have a good relationship with a lot of my patients, and so there's a lot of trust that has eventually developed. So there are a lot of different factors that I would say, why this isn't happening or why it is happening.
I wanted to add, if you look at the participation of African American and Hispanic in medical research, and I would say, and I came across some figures and cite 5%. So let's say if you have a study where you have 5% only the minorities participating, and then you have, end of the day, the results of the research, it's difficult to apply this research on everybody while you have only participation of 5% minorities.
Right, you say you have 5% participating in research, but you may have 14% who actually have the diagnoses, or even fewer who are actually donating their bone marrow. So that's a big problem is when you're talking about advancing treatment for this population.
Are there strategies that you would give doctors in, kind of having those difficult conversations with their patients? What have you seen as far as how you approach the conversation, how you carry yourself in the room, that helps patients kind of come to a place of trust and understanding to trust you as a provider?
I would say for me, it's just really being authentic and being who you are. I am very approachable with my patients. Half the time I'm not even in a white coat, and that is for that reason, because they feel comfortable actually seeing me. And with that being said, there is a relationship that is built with these patients. I think, having a long-standing condition such as a cancer, I mean, you have a really long relationship, a long building and lasting relationship with the patient. And so, from the moment that they're diagnosed, if they feel that they can trust you, they're more inclined to kind of do what you say, right? To get involved in research, to actually go ahead with the treatment options and not really be skeptical. And that's because of the relationships that, you've built.
Right. I mean, when they come up for a first interview, I think the first impression is very important. Your relationship with the patient and his caregiver and his family and loved ones is very crucial. They are overwhelmed. They are, devastated by at times when they have the diagnosis. So they may not capture all what you tell them, and it'll take some time and more communication. And it's not one time and done. You have to re-emphasize on those important issues and make sure you establish good rapport with your patient and their families. So then it will be easier to relay your messages, what's important in life and how to focus on those.
So with me being a woman of color, I tend to go out in the field. I'm in the trenches, and I am very involved in a lot of community organizations, and so I do a lot of talks, and so I actually get even a lot of my referrals based off of patients' friends, family members, churches, whomever, and so I think that is definitely from one of my strategies, and actually being an advocate to these patients and having them be able to identify with someone like myself.
What are the most exciting developments when it comes to multiple myeloma research, treatment, diagnosis, and
I think that, as I said, we started in the 70s where we have only melphalan and prednisone, and we have time now where we have all the proteasome inhibitors, we have the immune modulators, we have the CD38 monoclonal antibody like daratumumab, and we have now the CAR T cell. Those cells are taken from patients and they are manufactured in a way so they can, when they are reinfused in the patient, those are his own or her own T cells. They're manufactured in a way so they can be infused again and attack the myeloma cells. So this is a CAR T cell is there and it's going to stay, and I think it's moving toward earlier stages of treatment. Now the other is called bispecific, not only the monoclonal antibody, there are bispecific monoclonal antibodies now where they can combine the CD3 T cells or the cytotoxic T cells from patients, and then bring it to a close proximity to the myeloma cells where they can express a surface antigen called BCMA or PECMA. So those bispecific monoclonal antibodies can combine and bring into close proximity the cytotoxic T cells into the PECMA, which is an antigen expressed on the surface of myeloma and can achieve a tumor kill. Those are the future. I think that, and that's why going back to the research, I think participation in research is very crucial. We would not get there without research.
You talked about bone marrow transplant. Are the transplants usually with the patient's own bone marrow, or is there kind of a gap in being on the donor list, and how are different populations impacted by that?
This is all goes under cellular therapy, whether it's bone marrow transplantation or CAR T cells. Now, going back to the bone marrow transplantation, what we mean by this autologous transplant, and the term autologous means same. So we take stem cells from the patient and re-infuse it in the patient. So allogenic transplantation is done to some extent, but it comes with its own toxicity, because now you're talking about the donor cells, you're talking about immune rejection, you're talking about something called graft-versus-host disease, you're talking about long-term use of immune suppression, high rate of infection complications, and high rate of mortality too. So it has very limited role, the allogenic transplantation, that's taking stem cells from a donor. The one I meant was autologous transplantation. In a simple process, so what happened is after 4 to 6 months of treatment, induction treatment, and if you find your patient is suitable for transplantation, meaning he had no and organ damage that can render the transplant toxic. And so then they get preparation to collect stem cells. The stem cells are collected peripherally from the peripheral blood after doing stem cell mobilization by giving a granulocyte colony stimulating factor. Now, once those stem cells are collected, they are put in the freezer. And then the next phase comes where they are admitted to the hospital. They get high-dose chemotherapy with a medication called melphalan that can achieve a tumor kill. And it can affect also the normal cells. So they, without reinfusing their stem cells, they would die. They would not survive it. So you have to salvage them after giving the high-dose chemotherapy by reinfusing them after 24 hours by their own stem cells. These stem cells are smart. They can, once they are infused in the blood, this is all collected from the blood and reinfused in the bloodstream. It's like blood product, exactly, and how you transfuse it. So, and then those stem cells are smart. They go into the bone marrow in a process called homing. So they go home. And then you stimulate those stem cells to produce other cell lines. Those are mother cells. You give them mucogen again, or granulocyte colony stimulating factor, and help proliferation of stem cells. This process takes, on average in the hospital, somewhere between 10 to 12 days. Some centers now, they feel comfortable by they monitor their patient as an outpatient closely every day. But for the most part, most centers will keep him for 10, 12 days. And once they are discharged, they will have close monitoring. That's autologous transplant.
Is there anything that you think that physicians that are thinking about focusing in this area, that are already in this area, often overlook or need to pay attention to when it comes to diagnosis and treatment, or even cultural competence that we haven't already covered?
Okay. Going the steps, I think the first step is to start right is to include multiple myeloma in a differential diagnosis when somebody comes with vague symptoms, anemia, bony aches, worsening kidney function, high calcium, something that you cannot explain. You need to put it all together. And once you start thinking about multiple myeloma and include it in your differential diagnosis, I think this is the first step. And then the second step is to order the right lab, because I've seen ordinary physicians, they not really focus on what is really required to establish a diagnosis of multiple myeloma. So as I mentioned, those tests are very important, mainly the blood test and the urine test. And once you get your blood test, then, and this indicate monoclonal, we call it monoclonal gammopathy, so then appropriate referral to hematology should take place as soon or as early as possible. And obviously hematologists will go through the bone marrow biopsy, through the ordering of imaging study, whether this is skeletal X-rays or PET CT scans. So this, I see this as a way to do it.
Are patients who are more likely to have things like anemia more likely to be overlooked when it comes to multiple myeloma diagnosis, and how can doctors kind of use that as a lens to give better care culturally?
I think, most anemias are probably more common than multiple myeloma. So you have anemia secondary to iron deficiency. So most of the time, your general internist is going to try to treat the iron deficiency. And if it corrects, then, hey, we may have an answer to that. But I think it's, once they see that there are still some laboratory abnormalities or something is not adding up, or they get tests and it's not making sense, then I think you just really should have a kind of more prompt mindset to refer out to a specialist. And I think that for me is a take-home point. When you feel that something is just not adding up, if there's still more questions, then refer to a specialist who can assist.
They come up with a criteria called the CRAB criteria, and this stands C for calcium. So the calcium is high, that's a red flag. Obviously, when I say calcium high, there are multiple factors that can do this. But again, think of CRAB. So C for calcium, R for renal. If you see worsening renal failure that you cannot explain, there's another one. A stands for anemia, and Dr. Rozell mentioned already. You go through the anemia workup, and if you correct the iron deficiency or B12 deficiency and still you have anemia, I think there's something else going on here. And then obviously bone, which is bone involvement and bone disease or an imaging study. If you see, somebody goes for a imaging study and see incidentally lytic lesions there, that's a red flag.
Yeah, and even to piggyback off of that, I don't want people to just think, oh, if they don't have the CRAB features, then this is not multiple myeloma. This is just kind of a mnemonic that was used when you were studying, and that is how you may have identified it. But you can have one without the other. You can have all of them. You can have just anemia, and you can still be identified as someone who has multiple myeloma. So I would say that if it's not making sense, then refer out to a specialist.
Are there any organizations or institutions that specifically cater to patients of color with multiple myeloma and like kind of helping them either overcome some of the insurance barriers or other educational barriers or things like that you know of? And if you don't, that's totally fine.
I don't know of any.
Gotcha.
Yeah.
You can talk about that. And then last question, just to close us out, same question that I asked, are there any factors that are often overlooked, any strategies that are often overlooked by doctors that could help improve patient outcomes, especially from a cultural competence perspective?
I would say, to my colleagues, just get the patients in the door. Get the patients in the door, do your general workup, and order some blood work. I think, to me, that is the underlying root cause analysis. If you can get some blood work done, as there is no screening test to identify this, if you see something wrong, then I think that will help us kind of diagnose the problem. Without doing an exam, without doing any routine blood analysis, you are really kind of missing a lot of patients who may have a diagnosis that we're not aware of. So if you can get them in the door, get them actually to come to seek a doctor, actually do preventative care, I think that's a home run for me. I am Dr. Rozell. This is who?
I don't know.
What's your name?
Mouhammed Kelta.
We work with Affiliate Oncology, and this is MD Newsline.